Okay, thank you for this introduction, and thank you for inviting me for this wonderful meeting and session. Before I start, I just share with you one of my language experiences. As you know, in Israel, there are about 1.5 or even 2 million Russian Jewish people. There were two waves of immigration, 1970 something and 1992 actually, 1991. So we do have many Russian patients, and many of them ask me if I have been born in Israel. So I tell them yes. So they say, so how come you do not speak Russian? So доброе утро, спасибо большое. Не говори по-русски, and I will talk in English. So I was invited to talk about some current challenges in oncology, and that was really a big challenge because there are many. From the very beginning and from many aspects. So I decided just to share with you some cases or one of cases that I've been treating recently, and I think it will present the many challenges that we do see today. So this is a 50 years old, never smoker, EGFR positive lung cancer patient. She is a very famous actress actually in Israel and in France. And she performed in many movies in France, and she is also a producer. She was judged in the Cannes Festival a few years ago. So she was diagnosed in October 2013 as a locally advanced disease. She was treated by chemoradiation. We do not have a mice, right? So, and as you see, her disease is, I can see here, is locally centralized, and after a few time, not a long time, she had brain disease that was radiated locally. Okay, less than 6 months later, she had metastatic disease with liver metastasis, brain and bone. She was radiated to the brain in a whole brain radiation that was actually not the appropriate therapy today for those patients. And then she started biological therapy by tablets. At this case, it was named gefitinib or Iressa. A year later, her disease has progressed. As we all know that patients with cancer normally progress, unfortunately. And we were seeking to find what is the next drug to put her on, because we do have next generation of drugs that can block specific clones evolution. So we performed a liver biopsy that was negative for this type of mutation. We could put her on chemotherapy, but we performed another sophisticated platform doing a liquid biopsy, meaning to capture DNA, tumoral DNA, and do gene analysis on the liquid DNA. And that was positive for this drug. The liquid biopsy is one of the novel technologies that would make precise diagnosis in a much easier way. There is no need for biopsy. We just take blood. We extract DNA from the blood and do a full sequence, actually. And we can tailor targeted therapy upon a blood sample. So that is very convenient for many of our patients. So I will not go into details, but what we have seen in the liquid biopsy that she did have this previous abnormalities on the DNA, but she also presented a very rare, uncommon mutation that we did not allocate at the beginning. That was her PET scan. As you see, the PET scan was very positive. All the black dots indicate bone metastasis with a lot of pain, but still she was insisting to film a new movie in France. And in 2 weeks after performing the appropriate diagnosis, with a single tablet per day, her PET scan was much better. What was interesting to see is that even though that most of the lesions have disappeared, her liver lesion, and if you can see here, that was negative on the biopsy, did not show a good response. So it means there is tumoral heterogeneity, and tumor is not a single disease, even in a single patient, which may become a very significant challenge in our daily practice in the very soon time. So we repeated the liquid biopsy after 1 month, and what we have seen on the upper side of the slide is this rare mutation at the location of 724 went up by 100 folds. Even though that the resistant clone, the T790M, went down to the undetected level. So it means that the therapy is appropriate for a single clone, but is not working for the other clone. So it brought us to the need to another sophisticated platform that we were able to predict the response of the resistant clone to another type of EGFR blockade, which is available in the market, which called afatinib. And at that time, we gave her 2 types of EGFR blockades by 2 tablets per day instead of 1 tablet per day. So it was different drugs, same in general, blocking the same gene but different clones. And that was actually very efficient because and as you see, the rare clone went down again by 100 folds, and the PET scan on the right side looks better. So everyone was really happy, and she was able to tolerate the drug in a very good way. However, not for long, and the tumor was more sophisticated, and we were able to allocate new type of resistant clones again and again and again. And we had to put her on chemotherapy by the end of the day that she was not willing to accept. And unfortunately, as you see by liquid biopsy, not by a tissue biopsy, we can see here on the bottom line that the liquid biopsy not only allocate what type of clones you have in the disease, you can also quantify the burden of the disease by a single blood sampling. So what do we learn from this case? First of all, we learned that cancer is a devastating disease and very frustrating. We chase it and we chase it and we chase it, and this is kind of a losing game. So we have to do something in a different way. We also know and see that cancer may attack young people. Those people can go back to the community and produce some workload, etc. We also learned that cancer is evolving and changes over time. So it means that it is not that we put a patient on a successful treatment and it will work forever. And we also learned that novel technologies are available and they allow us to track single clones of the disease, not only a disease. So we are not treating patients with cancer anymore, and not with lung cancer anymore, and even not with EGFR anymore. We are treating a clone number 1, clone number 2, and clone number 3. And what does it mean? It means that we are going to personalize the therapy for every patient, and it means that we are going to burn more and more resources, time resources, money resources, gene resources for every individual. And this is really challenging because the number of physicians is not high enough, not enough lab infrastructures, not enough technology infrastructure, and this is going to cost a lot of money. So I definitely think that we should think about going backward, primary prevention, secondary prevention, and for those patients that do need a sophisticated platform, we have to enlarge and to educate more staff in order to be able to follow those challenges. So, and of course, time and attention is going to be increased for every single cancer patient. So it's not only number of patients that we are dealing with, we are dealing with an extrapolation of time that we have to invest in a single patient. And this is going to be very sophisticated. You know, I just returned from a journey in the Far East, also in China, and I've learned that a single oncologist, and also in Turkey, a single oncologist sees more than 90 patients per day. So I don't know how you can control quality assurance when you treat 80 or 90 patients per day. It is impossible, not for the patient and not for the physicians. So this is really a concerning factor, and we have to think how we can improve and train some staff to make our work more efficient. So those are the mortality curves in lung cancer 20 years ago. Never mind what complex of drugs we were using, patients were dying in the same process. And this is what we have today. If we do targeted therapies, patients can live 3 and 4 and 5 and 6 and even 8 years. And more than that, we can see that if we use more advanced therapies like immunotherapies with a single agent, even without chemo, we can see that half of the patients will live more than 30 months without even a single molecule of chemo. And this is kind of a big breakthrough, and it is going, again, very good for the patients, but on the economy side, it will expense a lot to the community. Of course, in lung cancer, we treat patients upon molecular profiling, so it means those multidisciplinary teams should have pathologists, should have a very precise molecular lab, and those abilities are not always available. The molecular profiling helps the oncologist to tailor the treatment in a very predictive way. So it is important for a patient to know that his chances to response to treatment is going to be 60%, 70%, not only 20 or less than a coin. And this is very important regarding compliance of patients. If we perform a precise gene analysis, we can subdivide the disease to many subgroups, which means that each patient will get its own individual therapy. And we also can put patients on many clinical trials. Clinical trials may reduce the expense of healthcare because the companies will absorb many of the expenses. And as you see here, as much as we go to a better technology on the upper side of the slide, we can cover many of the abnormalities. So we can again make time to treatment shorter if we use the appropriate technology. We do have many drugs that have been approved in Europe and and by the FDA, and many of those drugs are too expensive to enter the European countries, especially, for example, in Russia, many drugs are not being reimbursed because of the high expense of the drugs, and we have to find a way to make the expenses lower. So just to summarize, so we have collection of challenges when we treat cancer. Of course, we have population the need for population screening and education. There is diagnostic challenges associated with availability to healthcare, technology appropriate, etc. We have to educate staff and not only physicians, molecular technicians, nurses, healthcare supportive. So it's a lot of education efforts. Clinical and biological challenges are always there. We treat the cancer in a one way, and then the cancer evolves and changes, so we have another challenges in the next day. Drugs are not available always, and technology is always changing, and if we are, many centers put a lot of money in order to build an infrastructure. It is very slow, and until they finish the installation, this technology many times is not relevant anymore. So we have to make the decision makers to take a decision in a faster way. And of course, all of this will require a lot of expenses. It is all mainly, I would say, question of priority. We have to make the appropriate priority, and we have to stay dynamic and to change our decision while we are going. So with that, I would like to thank you. I hope I was able to transfer my insights of the challenges, and thank you.